I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
The final formal presentation of the morning will be given by Richard Weiner, entitled Electrical Dosage, Stimulus Parameters, and Electrode Placement.
I am sure at this point that both panel and audience are relieved to find themselves nearing the end of the formal presentations. That's the good news. Bad news is that within the next 25 to 30 minutes, I'm going to talk about 3 more topics. I have the slide. And these topics are electrode placement, stimulus waveform, and stimulus intensity. Fortunately, there is a saving grace that all of these topics actually deal with a common underlying issue vital to the ECT process. That is, the manner in which electricity is used to produce generalized seizure activity. As we shall see, a variety of modifications in ECT technique exist, each widely used on a worldwide basis. We shall also see that potential differences among these techniques occur with respect to efficiency of seizure induction, therapeutic efficacy, and adverse effects. Because of time factors, the major focus of this presentation will be upon the use of ECT in the treatment of major depressive disorders. This condition is by far the major indication and is also the source of the great majority of pertinent clinical investigations. As already mentioned by others, the electrical stimulus used to induce a seizure with ECT must pass between 2 stimulus electrodes. These are attached to the scalp in such a fashion that sufficient stimulation of underlying cerebral neuronal structures occurs so that a generalized seizure will be elicited. For the most part, stimulus electrode placements used with ECT are of 2 types. The first, termed bilateral placement, involves the use of electrodes located bifrontotemporally so that the resulting current path travels diffusely through anterior cerebral structures. The second type of electrode placement, called unilateral ECT, involves the location of both stimulus electrodes over a single hemisphere. This slide, representing a lateral view of the head, depicts the standard frontotemporal location, which is common to all types of electrode placement, and also shows the position of most locations which have been proposed for the second electrode used in the delivery of unilateral ECT. As already mentioned by others, unilateral ECT produces considerably less memory impairment than bilateral ECT, at least in terms of the functions of the cerebral hemisphere contralateral to the stimulation. This next slide, taken from a recent review by Framack, illustrates this point. In concordance with what has been presented earlier by others, bilateral ECT affects both verbal and nonverbal memory functions, which are believed to be mediated by dominant and non-dominant cerebral hemispheres, respectively. Dominant and non-dominant unilateral ECT, on the other hand, appear to only affect the type of memory function ascribed to the ipsilateral cerebral hemisphere, while leaving contralateral hemispheric function relatively intact. This means that unilateral dominant ECT affects verbal memory, and unilateral non-dominant ECT exerts its effects upon nonverbal memory phenomena, such as figural information and spatial relationships. Since the great majority of individuals appear to tolerate nonverbal memory dysfunction much better than verbal impairment in their everyday lives, the use of non-dominant unilateral ECT has generally been preferred over the dominant variety. This choice has also been supported by evidence from a number of studies that non-dominant unilateral ECT is more therapeutically effective than its dominant counterpart, at least in the management of depressive disorders. For these reasons, we shall, for the purpose of the present discussion, limit ourselves to comparisons of unilateral and non-dominant ECT with bilateral ECT. Whereas there is little disagreement among investigators as to the short-term differences in memory effects of unilateral non-dominant versus bilateral ECT, there still remains some uncertainty as to how long such effects persist. In my review of the pertinent literature for this presentation, certain minimal criteria were defined for study inclusion in order to assure at least some degree of validity and in order to more easily allow comparisons between studies. To be acceptable, studies had to involve the use of primarily depressed subjects who were randomly assigned to either unilateral non-dominant or bilateral electrode placement and who were tested both before and after the ECT course using objective measures of memory performance. In addition, follow-up of memory measures had to extend more than a week after the completion of the ECT course. In all, a total of 7 investigations were found to meet these minimal criteria. As outlined in this next slide, these studies tend to suggest that most objective evidence of differential memory effects greatly diminishes within the first couple of weeks post-ECT. At the same time, however, there remains some data to support the possibility of more persistent effects. This is shown most clearly in our own data, some of which will be reported in the Annals of the New York Academy of Sciences volume on ECT, which is in press. In this study, we found that out of 7 objective measures of memory function, 1 test dealing with autobiographical memory function for the period prior to ECT continued to show evidence of increased forgetting at 6 months post-ECT for those subjects receiving bilateral treatments. As shown in more detail in this next slide, our tests proved quite sensitive in establishing robust acute differences favoring unilateral non-dominant in verbal antegrade and various types of retrograde memory function. The persistent differential effect in autobiographic memory performance is also quite robust, with a significance level of 0.005. In line with material presented by Squire earlier at this meeting, autobiographical events occurring more recently with respect to the ECT were most likely to be forgotten. Interestingly, there was no significant correlation between this persistent autobiographical recall capability and the subject's own self-ratings of memory performance. This suggests that in this sample of rigorously diagnosed depressed subjects who were randomly assigned to electrode placement type, the subjects themselves did not feel affected by this increased level of forgetting. Self-perception of memory function months after ECT was not only found to be unrelated to ECT type, but was also observed to be unrelated to objective memory performance per se. Instead, self-rated memory measures were found to be highly correlated with the degree of clinical improvement in depressive symptomatology. This is consistent with the findings of a number of other groups who have established that depression itself is associated with significant memory dysfunction, particularly when tested by self-ratings of memory function. Relief of the depression typically leads to a marked subjective sense of improvement in memory capability, regardless of treatment modality. This occurred for people in our subject group who did not even receive ECT. While ineffective management of the depressive episode is likely to lead to a continuance of such complaints, we were also incidentally able to test one of Reagan's hypotheses. In other words, his claim that what is perceived to be improvement is really organicity. We found absolutely no correlation between degree of memory impairment and degree of improvement, regardless of whether the improvement was measured in terms of objective interviewer-rated measures or the subject's own perceptions of degree of improvement. Moving along to therapeutic efficacy considerations, close to 40 studies were reviewed which purported to compare clinical outcome as a function of electrode placement. Once more, minimal study criteria were applied to allow a more meaningful comparison to take place. To be accepted with respect to the present analysis, subjects had to fit some sort of criteria for the presence of a depressive disorder and must have had their assignment to unilateral non-dominant versus bilateral ECT take place on a random assignment basis. In addition, clinical outcome measures needed to be sufficient to ascertain on other than merely a self-report basis the extent of therapeutic response to the index course of treatments. Applying these criteria, a total of 22 studies involving more than 1,000 subjects remained, as shown in this next slide. Whereas 10 of these studies found no apparent difference in ability to induce a therapeutic remission, 8 described some sort of trend favoring bilateral ECT, be it with respect to degree of therapeutic response, number of ECT treatments necessary, or some other factor. An additional 4 studies reported a statistically significant therapeutic advantage for bilateral ECT. In keeping with other attempts to review this topic, it is difficult to interpret the discrepancies with regard to these studies. As will be discussed shortly, it is possible that technical factors may account for at least some of these differences. But it still remains quite possible, given the extent of such findings, that there may be at least some patients suffering from depression for whom bilateral ECT may be more rapid, if not more effective. Unfortunately, there is at the present time no way to predict who such patients might be, except for data that we have heard alluded to earlier, including some by Dr. Small, who indicated that individuals with certain types of manic symptomatology, regardless of diagnosis, may fit into such a category. It is probably worth mentioning in this context the findings of a 1980 3-month prospective investigation undertaken in Great Britain by the Royal College of Psychiatrists. Although this type of study by its nature does not fit the criteria met by the 22 studies listed in the present slide, its extremely large scale makes its findings of some interest. This prospective study covered over 2,500 courses of ECT, representing about 80% of all ECT treatments given during that time period in Great Britain. 76% of the ECT courses used bilateral electrode placement, a figure probably similar to that present in the USA. In cases when both patient and doctor were felt to agree on the degree of clinical response, unilateral non-dominant ECT was felt to be as effective as bilateral ECT, with approximately 90% showing at least moderate improvement. Still, it is interesting to note that a higher percentage of those with great improvement, specifically 65% versus 58%, received bilateral ECT. Another pertinent finding was that a disproportionate share of unilateral ECT patients required more than 6 ECT treatments. Digressing for a moment back to the issue of amnestic changes, the fraction of patients reported to demonstrate, quote, persistent impairment or, quote, continued complaint, end quote, of memory dysfunction after the first few weeks post-ECT was listed as 1% for unilateral non-dominant ECT and 2% for bilateral ECT. These latter figures were not found to be statistically different. Given the possibility of a therapeutic advantage for bilateral ECT, at least under some circumstances, the issue arises as to what one should do clinically in the case of a patient who is not responding to a course of unilateral non-dominant treatments. There have been suggestions that a switch to bilateral ECT be considered in such a case. Unfortunately, this issue has not yet been adequately investigated. Very recently, Stromgen reported a retrospective study in which patients not responding to unilateral non-dominant ECT, given using the D'Elia electrode placement, were either allowed to continue with unilateral ECT or were switched after 6 to 10 treatments to bilateral electrode placement. It must be pointed out that the experimental groups were chosen in a sequential rather than a random fashion, so that one must interpret the data with some degree of caution. The results of this study, as shown in this next slide, suggested that patients who were switched to bilateral ECT were no more likely to attain a level of considerable improvement by the end of the ECT course than those who continued to be treated with unilateral non-dominant ECT. Certainly, if such findings are replicated, they would not provide support for routinely switching unilateral ECT non-responders to the bilateral modality. Now, as already mentioned, a wide variety of types of unilateral ECT exist, differing mainly in the location of the second stimulus electrode. The high centroparietal location proposed by D'Elia is believed to represent the most efficient of those with respect to ease in inducing a seizure. In fact, it appears that seizure thresholds with this type of unilateral electrode placement are actually less than that encountered with bilateral ECT. A number of investigations have indicated that this is certainly not the case with alternative types of unilateral electrode placement. The reasons for the relatively high efficiency of the D'Elia placement are several-fold. First, some alternative placements, especially the frontal location proposed by Mueller, are non-optimum in that underlying skull thickness is particularly high. Secondly, the regions of cerebral cortex which lie in the maximal current path with the D'Elia placement are believed to have a high intrinsic level of neuronal excitability. Finally, unilateral electrode placements with short interelectrode distances, such as that associated with Lancaster et al., may not permit adequate excitation of underlying neuronal structures because of increased shunting of current through the scalp. For these reasons, it was decided to look once more at the 22 efficacy trials comparing unilateral non-dominant versus bilateral ECT, this time with respect to specific type of unilateral electrode placement utilized. As shown in this next slide, the great majority of studies utilizing the Lancaster placement did in fact find at least a strong trend favoring bilateral ECT. Those studies utilizing the D'Elia placement, on the other hand, showed an equivalence between unilateral and bilateral treatments, except for one study in which barely suprathreshold stimuli were used. Although the numbers of studies using the D'Elia placement are too small to allow an adequate statistical comparison in this regard, these findings do suggest that there may in fact be a role for specific choice of electrode placement in the optimization of unilateral ECT technique. At this point, a number of conclusions can be drawn with regard to unilateral non-dominant versus bilateral ECT in the treatment of major depressive disorder. First, there is clear and unequivocal evidence that the bilateral ECT produces more memory impairment than unilateral non-dominant treatments. Next, though this difference certainly tends to disappear over time, the possibility of a residual spotty loss in personal or autobiographical memory function, particularly relating to the weeks and months immediately prior to the ECT treatments, still must be considered for at least some patients receiving bilateral ECT. As already mentioned, however, a typical patient with such a finding does not seem to be affected by its presence. Next, for many patients, unilateral non-dominant treatments appear to be as effective as bilateral ECT in inducing a therapeutic remission. Still, there continues to be evidence that bilateral ECT may sometimes be more therapeutically effective, rapid, or enduring than unilateral non-dominant treatments. Finally, there is some suggestive evidence that attention to technical factors such as electrode location may increase the efficacy of unilateral non-dominant ECT. Now switching to our next topic, the choice of the electrical signal or stimulus waveform used to produce seizures with ECT has varied considerably over the history of this form of treatment. The next slide illustrates four major classes of such waveforms. In each case, current or voltage is shown vertically, whereas the horizontal axis represents time. The continuously oscillating waveform represented by the sine wave stimulus was the first to be utilized with ECT, most likely because of ease in design of instrumentation. Because of its proven efficacy, it has remained the standard type of stimulus waveform, at least in some countries such as the USA. Early attempts in the 1940s to modify the sine wave stimulus in order to arrive at a more energy-efficient means of inducing seizures resulted in the partial sine wave stimulus, which is used extensively in Europe at the present time. The brief pulse stimulus, although originally introduced in the 1940s, did not reach wide use, at least in the USA, until the last 10 years, when appropriate instrumentation became available. The brief pulse stimulus is particularly energy efficient, with our own studies, as well as others, indicating that it requires only about 1/3 the amount of electrical energy as the sine wave stimulus to produce a seizure. The final general type of stimulus waveform is the ultra-brief pulse, which, as we soon shall see, must be differentiated from the somewhat wider brief pulse variety. The investigation of high-energy versus low-energy stimulus waveforms has not been as extensive as that with regard to electrode placement. A total of 6 different studies were located which considered the differential effects of stimulus waveform upon memory dysfunction with ECT in a controlled, prospective fashion. These studies suggest that within the first few days following completion of a course of ECT, high-energy waveforms appear to be associated with a greater degree of amnesia. At the same time, however, these effects seem to be short-lived. Most investigators who have worked in this area have felt in this regard that memory effects are more a factor of electrode placement than they are of stimulus waveform. Nevertheless, it is important to realize that some degree of differential effect does exist, probably on the basis of more intensely generalized seizures produced with a higher energy stimuli. This next slide shows data comparing memory effects of brief pulse and sine wave stimuli from our own recent investigation. At 2 to 3 days post-ECT, subjects receiving sine wave treatments showed substantially more memory change from baseline than did those receiving brief pulse ECT. By 6 months post-ECT, however, these differences seem to have disappeared. Once more, no differences were present, even acutely, with respect to self-rating of memory function, in line with the apparent greater dependence of this measure upon level of depressive symptomatology rather than objective memory performance. Relatively few comparisons of stimulus waveform have been made with regard to therapeutic response. The results of 7 such investigations are shown in this next slide. 2 out of 4 studies, which included an ultra-brief pulse waveform group, reported it to be less therapeutically effective. This is probably due to a less highly generalized seizure as suggested by early workers in this area. Interestingly, the only sham ECT study in recent years which did not find a clear therapeutic advantage for true ECT was also the only one which reported the use of ultra-brief pulse stimuli. Studies comparing brief pulse, partial sine wave, and sine wave stimuli have been uniform in their absence of differential effects. This suggests that most types of stimulus waveforms used with ECT may be equivalent on an efficacy basis. Still, it must be pointed out that the number of studies which carried out therapeutic comparisons of different types of stimulus waveform have been relatively small, so that this issue cannot be considered settled at the present time. Summing up, in terms of comparing low-energy versus high-energy stimulus waveforms, it is possible to conclude that high-energy waveforms produce more acute memory impairment than low-energy waveforms, but also that this difference seems to rapidly disappear. Also, one can conclude that no apparent therapeutic differences have been observed to occur on the basis of stimulus waveform, except that ultra-brief pulse stimuli may not be as effective as alternative waveforms. My final topic for today will be stimulus intensity. Once the decision as to type of electrode placement and type of stimulus waveform has been made, there remains the issue of how to choose the settings for stimulus parameters. While available parameters vary from machine to machine, sine wave or partial sine wave devices are potentially capable of allowing either current or voltage levels to be varied, along with the duration of the stimulus. For pulse ECT devices, an even greater number of potential stimulus variables exist. These include current or voltage, number of pulses, pulse rate, that is, number of pulses per second, and pulse width, that is, the duration of each individual pulse. It must be pointed out that not all ECT devices allow for adjustment of each of these potential parameter types. Some ECT devices presently being marketed in the USA, for example, allow only the variation of a single specified parameter, for example, number of pulses. While research into the establishment of optimum stimulus parameters has been limited by a relative inapplicability of animal models, parameters within any specific waveform class appear on an empirical basis to be within certain limits roughly interchangeable. Because of this, no unique optimum configuration of available settings can be considered to exist at present. As illustrated in this next slide, one factor in the decision regarding stimulus intensity dosage with ECT, regardless of specific parameters chosen, is the patient's seizure threshold. This present data is taken from a compilation of over 2,000 ECT treatments carried out at Indiana and Duke universities for an American Psychiatric Association task force on ECT devices. In this slide, the range of stimulus output energy in joules or watt-seconds delivered by a commercial brief pulse ECT device is shown. The energy figure was chosen because it takes into account all potential stimulus intensity parameters. At both centers, stimulus intensity settings were titrated up or down depending on the duration of the induced seizure. The distribution shown in the slide therefore represents a rough estimate of seizure thresholds across a large group of patients. One can easily see that in some cases, less than 5 joules of energy was delivered, whereas in others, 60 joules, or very rarely even more, were required to produce a seizure. This distribution, which is qualitatively similar to that obtained using a sine wave stimulus, points out the wide range which exists in seizure threshold. It must be pointed out that not all of this is secondary to inter-individual variability, since it is quite common, as mentioned by others, for seizure threshold to rise substantially over a course of treatments, at times necessitating increases in stimulus intensity settings. There are a number of different philosophies which exist with regards to stimulus intensity dosing with ECT. Some have advocated very tight titration procedures with respect to seizure threshold. One unfortunate byproduct of such technique, however, as demonstrated schematically in this next slide, is that missed and/or inadequate seizures may frequently occur, particularly with unilateral electrode placement, necessitating the widespread use of repeat stimulations and/or additional treatments. At the other end of the spectrum, routine selection of maximal stimulus settings has been advocated, usually with the argument that this will assure that seizures are easily produced in all patients. Some presently marketed European ECT devices are actually designed around such a philosophy, offering the user no choice whatsoever with regard to adjustable parameter settings. While studies in this area are certainly few, it does appear, however, that maximally suprathreshold stimuli may be associated with an increased level of dysfunction, and in addition are probably not associated with any increase in therapeutic efficacy. Because of this, many ECT practitioners use a rough stimulus intensity titration procedure by which intensity settings are matched to seizure threshold, but in a way that at least moderately suprathreshold intensities are achieved. Such a procedure represents a trade-off between efficacy and adverse effect considerations, and in the absence of more definitive work in this area, seems quite rational. In summary, a number of relevant points can be made concerning stimulus intensity considerations. First, seizure threshold varies greatly, both among and within patients. Next, usage of a low stimulus intensity with respect to seizure threshold may be less therapeutic, while on the other hand, grossly suprathreshold stimuli may be more toxic. Accordingly, an optimal stimulus dosing strategy likely involves the use of moderately suprathreshold intensities which are titrated to the patient's seizure threshold. For this reason, it is felt that ECT devices must be capable of delivering a wide range of stimulus intensity settings via at least one adjustable parameter. As with stimulus intensity dosing, many questions remain to be answered with respect to stimulus waveform and electrode placement. That's the end of the slides anyway. I was just turning them on. As I said, many questions remain to be answered with respect to stimulus waveform and electrode placement issues as well. Certainly, the time does not appear right for making hard and fast conclusions which have the potential to limit further investigation. Still, it is important to recognize that the work so far accomplished in these three areas has already allowed the opportunity for some degree of improvement in ECT technique to enter the portals of clinical practice. Thank you.
Thank you very much.
One shock treatment can equal 150 joules of energy. This is equal to dropping a hammer on someone's head from higher than a 5-story building.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320-some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer I used to hit a hammer. I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but that may be the point. I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment.
What's that?
Conductant.
Oh, that will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well,
Now just bite down on it. That's right. Just bite down. Now bite down on it.
good. Are you ready?
Ready.